Hello, everyone. Malachi, did you want to say something?
I was just going to introduce you. Hello, everyone. Thanks for joining today. Mariam is a PhD candidate in the Griffith Lab, co-supervised by myself and Obi. She's working on a lot of different cancer genomics related projects, but she's really been critical to the established significance VCEP and the ClinGen Somatic effort, acting as a kind of coordinator and contributing a lot to pretty much all of the work in that group. And I think that's kind of where the topic today kind of stemmed out of, although it's also pretty cross-cutting. So I'm really pleased to introduce her and to listen to her presentation on this topic.
Thank you, Malachi. Hello, everyone. I think this is the first time I'm in a VIC meeting, call meeting. So I will share my screen and update you about what we have been doing for the past like 1 year and a half. I think I'm trying to, let's just say it. Oh, sorry. I think you see my slides, right?
Yep, looks good.
Properly without the notes? Yes. Okay.
Yep, looks good.
Okay. So we have been working on an SC-VCEP as part of the ClinGen that we call it the established significance or somatic variant of established significance clinical SC-VCEP. And it's okay. And as you can see, this has been updated, of course, and I believe we have an additional two SC-VCEPs. But for our established significance SC-VCEP panel, we are here. It's chaired by Obi Griffith and Yasmina Akari. We have been approved for step 1, and we're currently in submitting our application for step 2. I wasn't sure how much I should be providing background that is not just only focused on the functional assessment we've been working on. So I will give a little bit of a background for why we thought of creating this expert panel, the scope and mission behind it. So for this work of this expert panel, we have noticed there's some challenges that arise when we look and evaluate some variants that are regarded as clinical, established variant, or actionable variants. Mainly those that are listed under the FDA-approved diagnostic companion tests. What we found is that there was some inconsistencies or incompleteness in some reports or data elements, some ambiguity or lack of transparency in some of the FDA literature or documentation. There were some cases of poor variant characterization and or disease correlation, and also scattered information across databases that hindered the process of evaluating some of the oncogenicity of these variants.
Hey, Mariam.
Mhm.
Your video is kind of like flipping back and forth. It almost looks like it's inverting left and right or something. I'm wondering if you could like stop your video and restart it and see if that like,
Okay. Oh, I see just that slide, but let's see. Do you see that?
It's just your video, like your camera. Your screen
yeah, it's
sharing was totally good, but your
yeah, the screen
camera
sharing is
was
good, the audio is good. It's just that we see you kind of like bouncing around.
Oh, okay. So I'll come. So should I come
Yeah,
down?
try that. Yeah.
Okay. Let me know if it's not, it might be my second monitor doing something. Let me know if it's okay like this.
Now we don't see you at all, but
Okay, hold on. Is this, oh, sorry. Okay, how about now?
Interestingly, Malachi,
we
it
don't see you.
wasn't the case for me. I was seeing her just fine.
Oh, Wes and I were both observing the same
Huh,
thing,
Oh,
so we
interesting.
This
thought it was
this
struggling,
has
but
happened a few times on Zoom recently. This is a problem specific to Macs using Zoom. So
Oh, okay, yeah, because I'm on a PC.
Oh, I'm
yes.
on a Mac and it was fine for me.
Oh boy.
weird.
well, sorry to derail you, Mariam. I guess
Okay, well,
just keep
okay.
going.
yeah.
Okay, so yeah, but please stop me if you're not seeing my slides properly. So now I'm in slide of the interpretation challenges for variants of established significance. Do you see that one?
Yeah,
Yes.
that's
You don't
fine.
need to see me. Okay. Okay, I'll get on cam if something happens. Okay. And now do you see the SCV scope slide?
Yep.
Yes.
Okay.
Yes.
So yeah, our scope is to work on the FDA cleared or approved companion diagnostics. And we specified that we would like to work on simple variants defined as single nucleotide variants or small insertions or deletions or exon loss. Expectations is that we will be curating an AMP ASCO CAP Tier 1 level A1 for these variants. And also, most of them, we expected them to be classified as oncogenic or likely oncogenic. What was out of scope were biomarkers based on epigenetic or expression, copy number, variants, structural alterations, genome-wide mutational signatures like tumor mutation burdens. And some hereditary or predisposing variants were also excluded. And we also did not want to overlap with other current SC-VCEPs within the ClinGen working group. So this is what we started. This is the list of our list of genes. As you can see, we have 15 genes. And out of those, we were working on 299 variants, as you can see here in the right column. For the purpose of just showing exactly what we aim to do, I will be walking you through the example of some of the variants in EZH2. So as you can see, EZH2 has an approved diagnostic test in follicular lymphoma, and there's a Roche diagnostic test that tests for the presence of these 7, 8 variants. So what we do is that we go to the FDA companion diagnostic website. We checked all the documents, the approval statements. We tried to understand the logic behind approving these variants. How was the diagnostic test assessing them? How can we, because based on the presence of these variants, the patients are given or not given the CHASMplus drug. And then we checked for their recurrences in some of the hotspots data. We entered them in a very big sheet. We counted their occurrences and also in a relevant tumor type tissue in cancer hotspots, CBioPortal on Cosmic. We did initially assess for oncogenicity or functional oncogenicity predictions using open cravat and multiple tools. And for that, we also documented these scores. And by that alone, the progress has been so far, especially as the beginning of this year, is that we submitted the application, we got it approved on November 2023. We have reviewed a lot of documents to identify these genes and 300 almost variants. We did search about 120 relevant papers. I'm sorry, just spelling this. And we checked about 20 algorithms for all the variants using Open Cravat. As you saw, we checked for also recurrences data, and we classified these based on what we've done following that step progress. But then what we have been, and this was the progress over the past year, we have a lot of entered assertions and evidence items, and we also created all the variants that we discussed in the CIVIC database. But what took a lot of our time lately in the past few months was how do we finalize the in silico prediction for these variants? There is this just OP1 classification criteria at just one point, but there was a lot of inconsistencies when looking at some of the tools, the prediction tools. So we focused on comparing what the scores would be if we used Revel versus using CHASMplus. We felt like CHASMplus might perform better, mainly because it was trained on oncogenic or tumor data sets. So what I will be showing you now is some initial plots that we've created to look at this and evaluate this. So this is an EGFR. And in the plot on the left, you can see that in the x-axis, I hope that it's clear enough. There's every dot is an amino acid position in the EGFR gene. And on the y-axis, we have the Revel score on the left, and we have the CHASMplus score on the right. For the CHASMplus, we're using the general model here. Out of all these mutated amino acid positions, we have marked in red the FDA-approved variants. So we had that list, and we marked them as red. You can see that in orange, we have the most recurrent ones. So out of the data that we pulled for these variants, those that were marked as high recurrent across the databases were marked in orange, but if they are in orange and not in red, they're not FDA approved. And then those that are recurrent in NOMAD in a high frequency are colored in blue. What we did is that we struggled at the beginning with we thought a lot about what threshold should we apply in these cases, in both CHASMplus and Revel. We started by having the lowest or the threshold at the lowest FDA-approved variant. So you can see that this variant, FDA-approved variant, has this is the lower Revel score for it. And we thought of giving a point for anything that falls above it. So as you can see, Revel is it's not sensitive enough for only somatic variant. We're seeing a lot of variants being captured. It's not really logical enough, we thought, for a tumor in a tumor context. And also we did think that this might introduce circularity, that we did not want to rely only on one cutoff that is related to the FDA variants. When we did the same, but on CHASMplus, we did see a significant reduction in the number of variants passing that threshold. As you can see, I think a lot of the highest recurrent, all of the FDA-approved variants are obviously captured here, but we still thought that this is introducing that circularity of dependent on an FDA-approved cutoff. So that was the initial work we've done, and then we felt from the preliminary data that we do want to let go of Revel and just focus on CHASMplus. And this is a comparison between the two tools. As you can see, Revel is the rare exome variant ensemble learning. It's an ensemble method. It uses a lot of in silico tools to predict pathogenicity for missense variants or rare codon missense variants. Score, it's between 0 and 1 for both of them. The closer you are in 1, it's pathogenic. It's trained on rare neutral, rare disease variants. So it's mainly used for germline context. Whereas CHASMplus, it's a cancer-specific trained model on a lot of cancer data sets. It was trained on the TCGA data set, and it gives you an output of CHASMplus score or p-value. The closer you are to 1 in the CHASMplus score, the more probability there is that this variant is oncogenic or has an oncogenic potential. So this is the work of a rotation student that worked with us towards the end of last year. She took BRAF as an example and wanted to test Revel performance compared to CHASMplus. What she also did is that in our data set or in our pilot set, we have only 2 BRAF variants as part of the FDA approved diagnostic test. She also referred to literature to look at what is classified as very oncogenic, let's say, classes. She had some variants classified as class 1, class 2, and as class 3. She referred to a paper. Basically here, class 1 is an active monomer, basically any amino acid position in V600. And then for class 2, it's the consistently active dimer, so high to intermediate kinase activity compared to wild type. And then for 3, those are amino acid changes that are shown to have impaired kinase activity or are kinase dead. So these 3 classes, any variant fallen in them, we would expect them to be very relevant or very potentially to be oncogenic. As you can see, Revel misses a lot of them. So it performed poorly compared to CHASMplus in capturing clinically relevant variants in BRAF. As you can see here on the right, CHASMplus manages to capture them, but so based on this, based on this, we thought that CHASMplus also seems to be performing better than Revel. And then also, she attempted to compare the CHASMplus score versus the p-value. We created these plots for all of our genes in the pilot set, and we felt like definitely the score is more specific. The p-value obviously is more sensitive. But we ended up feeling that we can go with the CHASMplus score. And I think I have a slide for why this is what we ended up feeling, that this is the conclusions we have came up with following these exercises, is that CHASMplus shows better sensitivity and specificity in a cancer context in comparison to Revel. It incorporates cancer-specific features, making predictions more relevant. It focuses on identifying mutations that are likely to contribute to cancer because the dataset was trained on drivers or variants that are highly recurrent in databases. This also meant that we might be missing or underscoring some of the rare variants or those not reported a lot in some of the databases like Cosmic, but it still meant that we're also seeing better results with CHASMplus versus Revel. Sorry, I think I hit the p-value slide conclusion. Okay, no, I didn't. Okay. And then when it came to CHASMplus core versus p-value, we saw that specificity-wise, CHASMplus core identifies high confidence variant that are most likely to be oncogenic mutations. It worked really well across all the genes because of the scoring is based on a percentile. I'll show the plots for the rest of this set in a bit. But the weakness is that for both of them, p-value or score, is that it relies heavily on the robustness of the CHASMplus training data. What is not there, it will not score well. As for the p-value, it was more sensitive. It did capture rare but significant variants, but it becomes less sensitive when p-values are extremely small. And we did see that a lot in some of those sets. And I think this is an example of BRAF. I'm sorry, the plots are a little small, but if you see here on the left, we have CHASMplus scores by positions, and we have a cutoff of percentile. We initially thought of having a percentile cutoff at 98% to capture the top 2%, but we thought that would be strict. So in blue dashed line, this is the cutoff based on the 95th percentile. This is the CHASMplus score on the left axis. We're seeing all the FDA, obviously in BRAF, we only have one in this data set that manages to be plotted here in this plot, but we are capturing also all the recurrent variants in here. When you look at the p-value, the problem was, this is what we meant when the p-values are very small, it becomes weak. And then here we tried to transform the p-value. It misses, I would say it misses a lot. So this was based on this, comparing Revel from before, comparing CHASMplus scores, transformed values, and p-values. We settled on going with the 95th percentile of a CHASMplus core to continue with this criteria. So we walked through this slide, and this was our proposed approach, as I said. Setting it off to include the top 5 percentile ensures a fair comparison across variant categories, independent from the FDA variant scores, which avoids the circularity that we were facing in our first attempt when setting the threshold or the cutoff. It also prevents the over-reliance on a single score and circularity, as we said. So these are a couple of examples of our gene lists. If you look at the dashed blue line, I think we're capturing a decent amount of variants that could be oncogenic. Most of them are just the FDA-approved variants or really high recurrent variants. Some are not classified as, they're not either highly reported or FDA-approved. It opens the door to investigate them more, but most of them are around that position of whatever is high recurrent or known to be oncogenic, according to the FDA classification. For EGFR, we're seeing about 400. Sorry, if you look at the 95th percentile, we'll have 400 variants passing the threshold. If you look at the 95th percentile, which is what we ended up choosing or deciding to go with, we looked at ERBB2. We have a lot of variants reported as FDA-approved variants for ERBB2. Some of them are missed, I would say. So this was a unique case that we wanted to look at, and it's probably just because of the poor, most of them are either not recorded or reported highly in databases, so the training data would not give them high enough score. It's probably that reason. But I do think that it still captures, like 400 is a good, I think, amount of number, of course, compared to Rivel. This was like 2,000. For ESR, I think we're capturing the majority, but one FDA-approved variant. We're missing a couple of the recurrent ones, but I think it is related to the trained data and how many numbers it's seen. Also here, we're using the general or generic training model. I do have slides if time permits, and if people are interested in looking at disease-specific models, I have plots for them. But that was another reason that some of them are being missed, but it's still reasonable in our opinion. This is for EZH2. The ones that are being missed are really very rare in the databases. So these two variants are the least recurrent variants from our set in EZH2. So we know why they were missed. I think it does a little well. It does well in FGFR3. For KIT, we had only one variant in our pilot set. There's only one FDA-approved companion test for KIT. It's for the mutation or variant change in D816 positioning to valine. So it is captured. It has the highest score, but it's also the most recurrent one. We know that. IDH1 and 2. For MET, we have a lot of the variants that cause exon 14 skipping in MET. Problem is a lot of them are not easily to be first plotted, or because they're not that simple amino acid change position. So what we did is that we plotted the most recurrent ones, not only based on cosmic, but also based on cancer hotspot in here in green. The problem here is that it doesn't work, obviously, for MET because CHASMplus does not perform, doesn't give you back anything for exon 14 skipping. So for this reason, we're going to exclude MET from being evaluated through CHASMplus, and we're using Splice AI for now for this criteria. But I thought of adding this plot to show you. For NRAS and KRAS, I think they're doing pretty well following our approach. We have also RET. A lot of them were missing, but also it's related to how scars are not very prevalent they are and how poorly they're reported in the databases. So this is what I had for now, because I wasn't sure how much time I would have. But I do have, these are the members working on this group or this panel. I do have slides to show some of the results for comparing CHASMplus scores using the generic model versus a disease-specific model. If anyone is interested, I can also show these plots and these results. Hello?
Thanks, Mariam.
Yeah, sure.
Any questions or comments from the group?
Hi, this is Bob. Can I ask a question, Mariam? And obviously I'm just kind of new to this stuff, but when I look at the somatic submissions for ClinVar, and I see that they have 5 different axes by which you can submit, it looks as though what you're really doing is refining the calculation axis. And I just wonder if you could speak a little bit about how this work would influence our somatic submissions to ClinVar.
So I don't have a background about the submissions to ClinVar and how if there's a process or criteria to submit to ClinVar. I know we started doing it last year, I think, for Civic. Can you, Malachi, help with this?
I think if you're specifically submitting oncogenicity assertions to ClinVar and you're following the CGC, VICC, ClinGen, oncogenicity SOP, which mirrors the Richards et al. ECMG guidelines and has like sort of parallel evidence codes. This kind of consideration of the algorithms really affects like one of those evidence codes that honestly is like not a big player in the overall oncogenicity score for any particular variant, because people are generally distrustful of the oncogenicity like in silico predictors. So the sort of like big picture impact in the sort of near term is pretty modest. I would say it's sort of like helping us to decide whether we should give the 1 point. And I think there are kind of efforts being considered to try to decide when you might feel comfortable attributing sort of more weight to in silico predictors. But I think there's quite a bit of like work to be done still. I don't know, Wes, if you want to, or others, if you wanted to disagree or add on to any of that.
No, I mean, I agree. And I think, I mean, I've had some chats with Melissa about continue to further like add to the data model so that you can have more discrete fields for like the actual codes that you're using, and then even better on top of that, actually like structured evidence that's then supporting each code so that you can then kind of have all of that. But I think, you know, that's a lot to add, and ClinVar is a large project. And so I do think kind of being cautious, or at least trying to understand what's being submitted so far. I know that the Griffiths and Alex have been working a lot on being able to do submissions to ClinVar with GA4GH standards within there and everything there. And so I think there's lots of opportunities for continued improvement over the next couple of years. But I think we all would like to see more structure within ClinVar to help understand, you know, how we can better utilize other people's assessments within our own workflows.
Yeah, I think right now they allow us to link back. So if we create an assertion for the oncogenicity of a somatic variant and we conclude that it's likely oncogenic, that's sort of like mainly what gets shown with a few other annotations. But then we can link back to the like a source like Civic, which is what we're using for the ClinGen effort, where you can kind of see all of the details of like what evidence supported each of the evidence codes and how that added up to likely oncogenic or oncogenic, including how the in silico evidence was incorporated into that sort of final assessment.
Are you guys concluding that for the in silico predictions, you know, I guess in the current ClinVar submission guidelines, you can pick a lot of different in silico tools. You know, are you starting to conclude that, well, CHASM, why not just use CHASM as opposed to just picking anything you want?
I would say it's pretty contentious, across the 8 active thematic variant curation expert panels. Different choices have been made for different groups that have kind of different goals and are focusing on different genes or different types of curation. I think some of the groups look at the kind of evidence that Mariam's presented for Rebel, showing like if you just pick a Rebel cutoff of 0.7 or something, for some genes, there's just the pattern seems kind of disconcerting, that there's sort of potentially impactful variants across the entire length of the gene. And That's possibly correct, but that many of those impacts are probably loss of function. So when you're specifically looking at oncogenicity in an oncogene and you're thinking mostly about gain of function, that it doesn't seem appropriate. And the choices for what to do next have kind of varied from group to group. Some groups say like, okay, we're just not going to use an in silico predictor at all to give any points in the direction of oncogenicity, but we'll still allow it as evidence for benignity. So it's sort of like a conservative approach is sort of like if it says the variant has no impact at all, we'll kind of trust that. But when it says it does have an impact, we're not sure if that impact is likely to be gain of function or loss of function. Without that knowledge, we're not comfortable applying it to an oncogenicity assessment. Other groups have decided that, that's all the in silico predictor. What we were asking of it from the beginning was not very much. We just wanted it to distinguish between variants that are not impactful and variants that are impactful. It's only 1 point towards oncogenicity, which by itself is never going to cause something to even be likely oncogenic. So it's always going to be supported by other evidence. We're perfectly comfortable with this, and we're going to use Revel because that's what's been widely adopted and it's easy to use. And there's a publication, at least on the germline side, sort of like doing a formal calibration of Revel scores relative to evidence strength levels in the ACMG code system. And then there are other groups that like look at the kind of evidence like Mariam presented and say, you know what, the just sort of intuitive like result or pattern of the scores that comes out of CHASMplus just seems a little bit more reasonable, particularly when you're thinking about interpreting gain of function variants in an oncogenicity context for an oncogene. But with the caveat that it still actually isn't technically predicting gain of function. It still is. It's still unable to distinguish those two. It's kind of getting some help from some of the additional tumor specific data types that it incorporates. So the reasoning is like this tool still isn't really perfect, but it's sort of like closer to what we're thinking of when we're interpreting somatic variants.
Thank you.
I had a question about ESR1. I don't know how much work you did specifically on that, but the ligand binding domain, all of the mutations in that, like any missense mutation in that domain is basically referred to as on label for elacestrant. And I was curious if you had looked at that area and noticed if there are obviously certain mutations, the D538s, et cetera, that are well known to be oncogenic, but there are so many, we see so many mutations in that region that are that we would classify as variant of unknown significance or even benign, but any missense mutation in that region is defined as on label. And I was wondering if you had looked into that at all.
I have not looked specifically at that, but did you say it's position 300?
I can't remember the boundaries of the domain. I'll have to look, but it's around certainly surrounding 500. I'll take a quick look.
So yeah, okay. So I think it's okay. I'm sorry. I think I got first that. So for ESR, I think what I can see is that I can share my screen.
And why don't we look at it again just to
Yeah,
visual.
I'm sharing.
Yeah, it's 310 to 547.
So it's a pretty big region.
Yeah, yeah.
So I think you're seeing my ESR. Yes.
Yeah.
Yeah, okay. So for ESR1, you said it's from
310 to 547.
Yeah. So the FDA-approved ones are lying here about 570-ish something. We did not look
yeah.
excuse me.
It's 538, but yeah.
Yeah, about here. We did not look at the domain itself. We were following the oncogenicity codes criterias and given points if it's within the domain or within a domain. But we did not really investigate it specifically. But I think it's a big area. We can see a lot of the highest recurrent ones having very low scores. Maybe that has to do with what is classified as benign, but some of them are having high. But I think it's related to how much they're reported in the data phases. We did not.
When you say they're considered on label, that's based on what it says in the FDA approval, like it describes the
Yeah, the
domain.
FDA approval is very vague. And so well, the FDA approval specifically refers to the companion diagnostic. The companion diagnostic describes missense mutations in the ligand binding domain. It doesn't specify beyond that. So we've had multiple discussions with different groups about how to report those because it's for variants that haven't been defined, should they be the trial did not distinguish, basically. The trial took any variant in that region and applied elacestrant and then analyzed them as a group and didn't distinguish between based on the classification.
So I think I get what you're saying now. So actually, we did find a list of what we think were the variants they referred to. The main in a lot of those cases, the main documents and the approval forms missed or did not specify the variants. So we went to, in some of the cases, I don't remember exactly what happened with ESR1, but this is what I expect happened. We went to the diagnostic test assays document, and from that we pulled what the test is actually looking for and what it's testing. So that is how we came up with a list for ESR1. It's definitely not all the possible mutated positions in this domain, I would say, but we have a big list. It's maybe all of them. We do have a
So
big
those are
list
the
for
ones
every.
that happen to have been observed in the trial, probably.
Right.
In that
Yeah.
domain. Do they define like clearly what the ligand domain is? Do they?
Yeah, it's 310 to 547.
So they give like a sequence accession and say in this sequence it's from this position to this position.
Yep.
Yeah. So at least they did that.
Yeah.
But yeah, that seems much broader than most of the genes.
It is. That's why I was wondering if there were things that popped out of using this assessment that could help identify, which variants might be more likely to respond. I mean, it's impossible to say because the trial basically took all comers and then it was it's hard to say within that trial how any individual one would be likely to respond beyond the ones that are really well known.
Flashback to last year, Cheryl, we did the very same assessment, looking at the label and looking at the companion diagnostics and the evidence and debating how to interpret the wording. I don't even remember what we decided, to be honest. But yeah, it's not straightforward.
Yeah.
And yeah, the in silico evidence doesn't seem to help much. I mean, actually, Mariam, can you remind us what the gray dots, like each dot represents? Are these all missense?
Those are all the possible mutated positions. I'll share my screen again. So from 0, so this gene has 600, let's say, amino acid. Every dot is a mutated position. So what we did is that we actually went to Revel data, I would say data sets, because the Revel was conducted, those scores were conducted by mutating each possible position and then conducted a score for that position. So this is how we got the positions.
It's every amino acid change that you can get by a single nucleotide substitution of the actual sequence.
Okay. So that prompts another question is, maybe this isn't the best example, but for other genes where there's perhaps a relatively small cluster of alterations that may fall above the threshold that in the same range as one of the FDA-approved drugs, like have you been able to look at some of these gray dots and say, does anyone actually observe these things, or is that already sort of known based on your depiction here? Like if it's gray and it's a small dot, then it's never been observed.
I'm sorry, did you mean if it falls above
the recurrent and it's not in nomad, but I guess it could have been observed like below the definition of recurrent. What was the definition of recurrent that was used here, Mariam?
It's anything that is present. So here it's the highest recurrent 10, but they're not FDA approved.
Sorry.
So out of the all amino acids, I labeled first the FDA approved ones and gave them red, and then out of those, what is the highest 10, and give them orange based on cosmic numbers.
Just the 10 most observed.
Got it.
The next 10 most. Okay, so so some of the other ones could still be observed at some level as one-offs or two, or it would, So that would be interesting to also overlay on here.
But But I actually remember that out of we did want to also like look at why they have very high scores and they're not recurrent. Some of them actually are not reported at all. I did go back
Mm.
to look at them and they're not reported at all. So that would have opened maybe some doors to like investigate them further. And I think they're getting the high scores maybe mainly because they're around the same position or at the same position of other reported oncogenic variants, but
Mhm.
still they're not. The same exact amino acid change at that position is not reported. In a lot of cases, they're not.
And this is where you
Um,
really get into like the weeds of the algorithm, and it raises so many other questions. Like I think
Fair.
if you talk to the author of this tool, this is from the Karchin lab, um, she will say like, oh, it's not fair to say like, oh, this is just like reciprocating hotspot data. You know, it's trained on 80 features, like all kinds of diverse features, and you can go and look in the supplement and see all of the really sort of interesting features that were fed into the machine learning algorithm. But like two of those 80 features do encapsulate indirectly like recurrence information from observations in tumors. So, and you don't really know like how much weight is given to each of those features. So, like there's a legitimate concern about like double counting when you're using this tool. That if you're already giving points for recurrence, like are you kind of just to what degree are you just kind of like reproducing the same information with this predictor? So I think that's another debate that's going on in this space. It's really, yeah, tricky.
Yeah, presumably, and feel free to challenge this assertion, Miriam. Like where the in silico prediction would be really useful is for alterations that appear rarely or not known as, don't already have evidence. And so I'd be curious for those that like pass your threshold,
yes.
if we could assess them
Yeah.
in some fashion and say like, is this just a bunch of, is there any reason to believe that this would pass the smell test and would be valuable and specific enough to use in that situation to bump it over the line to, like the oncogenic or not. I'm not sure if that's an easy thing to do, but
If you
I
go
think
back to BRAF for a second, I think it's easier to
you're
kind
right.
of see. Yeah, I mean, so there are like, there's a bunch of things like two or three or four or five amino acids to the left or to the right.
Mm,
I think, yeah, if it does provide information for those that are just part of the long tail that like maybe just haven't been observed yet, but could actually be functional in a similar way, then I think it's serving its purpose. But to your point, Andy, I think that's not demonstrated. Yeah, like we would need to kind of convince ourselves that like that's true.
it might be hard to demonstrate. I'm not
Yeah,
exactly sure how you go
yes,
about it. Yeah.
yeah.
Oh, cool. Good. It's good to
I
hear.
Especially
mean,
if you
I
go
think
back to
like
the
MAVE data, maybe. I think there's some talk of like for a subset of genes where you have MAVE data and you have some kind of functional readout, you could ask like, but that
That's
data,
what I was going to suggest too, was using
Yeah.
MAVE data to overlay, and then you could see in these oncogenes like which alterations result in a kind of like an activating effect, and then overlay that with like in silico score and see how well these data jive. And to me, that's multidimensional. I'd probably feel better about calling like tipping the scales if both in silico and like a kind of like moderate or emerging functional data were like consistent with each other and
yeah,
to call something.
Yeah, I was just going to say also, oh, I agree with the idea of using MAVE data. I think also it's challenging with something like ESR1, where you're talking about disrupting a ligand finding domain, where there's like, what is the readout that you're going to use? And then you get into the challenge of like each individual, are you going to look at patient response? Well, looking at a single patient when there's so many different um, possible changes to that domain, it becomes really tricky because the p-values are like zero 0.8 or 1,
yeah,
which is why they, I think, kept it vague, because so many of them that are unknown and uncommon do respond, and they want to make it an option. So it's that balancing act between, do you want to make sure that you're choosing a patient that's going to respond, or do you want to make a therapy available to someone who might respond? It's difficult.
Yeah, I mean, I can imagine that there's still some utility in even in this zone that's sort of like a blob that seems to correspond to your region, your ligand domain. At least,
Sure.
again, coming back to like maybe for the ones that have a really low score, being a little
Mm-hmm.
bit less confident in those, because some of these things are really subtle amino acid changes that are almost not that different from a silent mutation. Like we wouldn't say like a silent change in the ligand domain would be therapeutic, I assume.
No,
So,
presumably
there are
not.
some amino acid changes that are almost like silent that because they're
Yeah,
such a like similar substitution.
right.
So, but when you get down to that level, it's like it's this really fancy algorithm that like, is it adding much on top of what you could get by just looking at
Yeah.
it? We're thinking about the amino acid change to happen. So I think that's a fair criticism too.
Yeah, I think the ESR one was one of the ones that were not the best. When we looked at it, there are 23 reported FDA, like out of the FDA documents, we found 23 specified ones, and still some of them are missed. You can see here, but most of them are at this position. So it did perform weird for this one, I do have to admit. And we did look at the specified data set for it for breast cancer. Did not do that much better than the general
Yeah,
one. That's
I
why
mean
we thought
the really clear ones are like the 536,
yeah.
537, 538. Those are the ones that are, and that looks like the region that you've got. And pretty much everything else, there certainly is a list that was published from that paper. It's just because it was assessed as a group, it's difficult to know.
Yeah, and they don't provide the patient level
Right. That's
readout,
right.
which would be really interesting, at least anecdotally, to say like, oh, well, there's this one that scored well, and oh,
Right. Right.
look at that, that patient didn't respond, but you don't get to do that.
Right. Right. Because, yeah.
How's an oncologist supposed to use that big approval? This is separate, the conversation for another day, but I find that really tricky. If here we're debating,
It's,
and I think we
yeah.
have a reasonable understanding of the biology and the molecular behavior of these things. So it's tough.
Give the
It's
drug and hope for the best.
Yeah, it's super
Well,
tricky. Yeah.
yeah. If the side effects are acceptable and you can get it covered by insurance, or who knows, lots of considerations. So perhaps oncologists are best positioned to make that call
I
without
think
full.
there's difference among oncologists also in terms of how, like, what they prefer to see in terms of, do I want to see a drug if there's any chance that it could work, or do I only want to see it listed if it's proven that it, is likely to have benefit? And that's you can't please everybody, so you got to figure out what's going to be your approach.
Right. And then also patient to patient, like has this patient been through 3 different rounds of treatment and they're looking
Hmm.
for something that is more experimental, or is this first round and you go with the tried and true and kind of standard of care applies? I mean, there's so many different variables, and yeah, I agree completely.
I mean, hopefully the tiering and the sort of more granular representations of evidence and confidence will start to like at least help to guide those, to give them
Yeah.
information to decide for each patient, like where they fall in terms of decision making.
And it depends how closely the oncologist, each individual oncologist is going to read the report also, because if you have information in the report that says this is a D838, D538G mutation, it's well established as a resistance mutation responsive to the elacestrant, then you're going to go ahead and do it. If you have random mutation in X, between 310 and 530, 547 that has never been reported or characterized, it might be less they might be less likely to do it depending on what other options they have. If they have no other options, they might say, well, we might as well try elacestrant, you know? So
Yep.
discussion. But just thinking about whether this will be another tool that can help.
I think
Thank
it
you.
provides a really nice framework if you want to layer other data on top of it and say, okay, yeah, these are the variants that have been functionally, shown one way or another to, add significance to this, or even like anecdotally, there are some genes where you can find a lot of variants in literature, wherever, that have responded to therapy, and kind of overlaying that with that data could be pretty powerful. So it's nice to kind of have that visual framework.
Yeah, and I think comparable to something like Splice AI for splice variants, when you have these mutations that are either, beyond the plus minus 1 and 2, or just adjacent in the exon, where it's hard, you can't predict. I mean, because it's different from every junction and every gene. But Splice AI does, not 100%, but it's starting to give us more information about whether something is likely to be a splice variant. So I think with these, maybe that can help as well.
Peter? I am not
You're
hearing
having
the
some
audio very
issues.
I
well.
think there's some audio problem.
Zoom is giving us all kinds of new challenges today. Not experienced these before.
Love a good Zoom gremlin every once in a while. It's been a while since their software has been a little unstable. This brings me back to the beginning of the pandemic.
Peter's maybe rejoining.
Yeah, give him a second. Anybody else have any other comments while we wait a second? Is he back?
Can you hear me now?
Yeah, there you go.
Yes,
Okay.
perfect.
So, Cheryl, I wanted to make a comment. It's sort of related to some of this. We developed information theory for splicing analysis, and back in 2020, we published a database of 330,000 splicing mutations that are validated. And we're in the process of actually using ClinVar's new functional validation criteria to upload all these variants, or many of them, to ClinVar. So those are in silico predictions based on 25 years of work, but then they're actually validated with the expression data in the tumors from which they are found. And it should be available later this year.
Oh, that's great. That'll be really helpful.
Now, the reason I tuned in today was because I can't say that any of these are oncogenic. Okay, I mean, but you can certainly see when you've got a cryptic splicing mutation or an exon skipping event, and our tests basically exclude alternative splicing, because we do a likelihood type analysis, and we get a p-value that it's not present in 100 normal tumors. So we're pretty confident in the fact that the variant affects a function, but we're not confident that the variant affects oncogenicity.
Yeah.
So if you are a genome analyst, and you have some idea that a gene is important for oncogenicity, but you don't know which variants in the gene do that, I don't know how much functional evidence will help you.
In terms of whether splicing is disrupted, or whether
Well,
there's...
I mean, we prove splicing is disruptive, and we give you a p-value. You can decide what threshold you want. We don't report anything below 0.05, but there's some very nice literature that suggests we should be using 0.001 or 0.005 as our criteria for a p-value. And again, we're comparing the likelihood of that abnormal splicing event to its presence in normal tissues, a large number of normal tissues. So we're pretty confident that it's a splicing event that doesn't occur in normal tissues, but we can't say anything about oncogenicity. You still have the same issue that has been addressed in this session today of, well, we've got this whole domain and we know there are certain variants in the domain are oncogenic, but there are plenty of others which clearly change the function of the protein, but they may not be oncogenic. And I don't know how you address that, frankly, unless you have really large numbers of patients, which for many variants you don't.
Right. Yeah, I agree. I mean, I think this splicing is really challenging because it's like a two-layer problem of you're helping to solve one layer, which is, does this variant actually impact splicing, which we can't know a priori necessarily. And then there's the next layer of does this splicing impact cause a loss of function or a gain of function?
Well,
And is that oncogenic?
if the splicing event changes the reading frame and it's
Yeah,
early
you would
enough in the,
expect that, yeah.
yeah, I mean, I don't have a doubt about, or the splicing event creates a cryptic site that's used exclusively and no longer gives you a leaky natural splicing event. But then even then you have this question of how much natural splicing is necessary to overcome oncogenicity.
Yeah.
Because a lot of splicing events are leaky.
Yep.
But that's true for protein coding changes that affect catalytic activity too.
Yep.
I think this has been a great discussion. Thank you all for your participation. Mariam, thank you for your presentation. Hope you all have a great rest of your day, and we'll catch you at the next one.
Thank you.